Good morning, ladies and gentlemen. This morning we have a special talk from Prof. Arun. He will give us a talk on pattern of the Fistula NO. At first, I would like to sorry about the little bit delay. Anyway, we are in the middle of a long weekend in Thailand. We have plenty of time to listen and discuss. If you have any question, please text to Q&A box. For the speaker, Prof. Arun, I believe there's no need to introduce him. His work represents his name, and he's a father of lift technique. Even he retired from us, he still work in the he has done a lot of work in environmental disease and fistula. He keep learning and he come back to teach us. Okay, I would like to send my time to Prof. Arun. Please, Professor.
Good morning, everybody. Today, we will talk about the anal sepsis pattern, not only fistula, but anal sepsis. I would like to start now. Anal sepsis pattern. I would like to divide my talks. The first part is the limitation of the fistula classification. And this will link to the anal sepsis pattern. And then I will give a lecture on the anal sepsis patterns and operative options. Oh, sorry. กลับไปอีกทีได้ไหม เดี๋ยวกัน sorry ไม่ I know sorry for okay, we start again about the anal sepsis. I one Second, the anal sepsis patterns. And the last is the anal sepsis pattern and tip. When I finish each part of the lecture, maybe we can interrupt with the question and answer. Okay? Well, let's start with the limitation of fistula classification. If we look at the available fistula classification, most popular, most widely used for a long time, maybe 40 years. And then we have Sumikoshi, which is popular in the East Asia, I mean Japan, Korea, some part of China. And we have Eisenhammer. I think, in fact, Eisenhammer, in my opinion, is the best. And then we have the very old one, the Milligan Morgan. And then the traffic. If we look at the traffic, you can see the abscess or the fistula tract pass between muscle. This is a good concept. It do not pass the fistula tract or abscess, do not pass the muscle, but pass between the muscles. And then recently we have the St. James MRI fistula classification, a recent classification from many places in the world. Let's start with the Park classification. Published in British Surgery in 1976. This theory, this paper, if we look very close, we will see something that we do not know before. It's a retrospective study. In long period of case series, 15 years, it means that they operate only 2 cases a month. It's a low volume paper on different anatomical knowledge. I will show you later. And the Park classification, the complete one, have 14 types, well recognized and used by others. And illustration of Park classification are misleading. I will show you. I will explain more. And no study reports similar fistula type and incident at Parks. And at that time, we do not have imaging and the inter-leg ultrasound. Of course, when someone look at the operative finding, sometimes you cannot know that this is which type, you cannot know, unless you support by the imaging study. Park classification, in fact, Park have the idea from Stelner. Stelner in Germany in 1995, he have classification. At that time, there are 3 types: intermuscular, transsphincteric, and extrasphincteric. No suprasphincteric at the time. But Park add more. If you look at the understanding of the anatomy by Park in that year, you can see the subcutaneous we included that these are subcutaneous. And the deep one, and this is the levator. The levator cannot divide into parts. So it's different. This understanding of anatomy is different from the modern anatomy. This is 14 subtype of Park classification. And you see it's too complex. And let's look at each classification of Park classification. When we look at the type 1, you can see that this is the intersphincteric type. But amazingly, the high intersphincteric type, this is the type. And this is very complex. The high intersphincteric type is very complex. And this is the same, is in the same type as the simple one. It's in the same type. If you put this picture to the student and ask which type it is, no one knows it's a type 1. But in fact, it's a type 1. So this is not correct. For the type 2, I need intersphincteric types. In reality, intersphincteric, the fistula type, pass between the internal sphincter and subcutaneous external sphincter is quite uncommon. I think it's less than 10%. But intersphincteric is 45%. In fact, these intersphincteric type include low intersphincteric and low transsphincteric together. Low transsphincteric is the most common fistula. You can see that the transsphincteric have the transsphincteric type. We do not separate, do not distinction between high transsphincteric and low transsphincteric. So these two types are in the same type. But the outcome, the operation for these two types is totally different. And if you report Park's transsphincteric type, we do not know it's a high or it's a low. So it's impossible to understand. For the suprasphincteric type, I think it's iatrogenic. The same as the extrasphincteric type is iatrogenic. I will show you more information. I will give you more information of these two types. Again, if you look at this picture, the transsphincteric, the picture, you have the internal opening in the lateral. This is unlikely, never happened. In fact, the high fistula, the high transsphincteric, occur at the posterior midline or anterior. It's very, very rare to occur in the lateral. So this picture is not correct. And come from here to involve ischial abscess is almost impossible. Let's have a look at suprasphincteric and extrasphincteric. It's rare. Most of them are oriented assessment. Most of them are iatrogenic sequelae, and illustration are incorrect and misleading. This is the suprasphincteric and extrasphincteric report from St. Mark Hospital. This is Park from St. Mark. You can see the first paper he reports suprasphincteric 20%, extrasphincteric 5%, but later, a few years later, the suprasphincteric dropped to 3%, extra 3%. And in the only 1 year, 1997, the suprasphincteric 3% and extra. So it's much different between the incidence of the supra and extra by the same hospital. Why this happened? I will explain. If we look at the comment written by Parks in his paper, he said, in case where the fistula were initially thought to be suprasphincteric, there was doubt of its exit tract. Either because the fibrosis prevent adequate access or because anterior charting of the fistula tract in case records. So even he do not know, but he said maybe it's suprasphincteric. At the time, if we have the MRI, we will know what it is. But at the time, we do not have the MRI. Okay, he also said that impossible to ascertain the location of the fistula in relation to the pubolactalis. The fibrosis sometimes so obscure the anatomy that it is impossible to be sure to the exact position of the pubolactalis. This is written by Park himself. This is a person who attends Parks all the time. Eisenhammer. He said many complex fistula described by Park result from faulty surgical treatment leading to iatrogenic disease. And many surgeons believe the Eisenhammer concept. Fusini said that in other clinical experience, this one also seemed to confirm Eisenhammer view of the non-existence of supra or extrasphincteric tract. No existence. And this is a recent series by Clark from India. He said no extrasphincteric fistula were found in recent large MRI-based study. this category were possible around this. If you look at another papers, he used the part classification to categorize the fistula. He said interfilling 48%, which is too high. I do not believe it. Transsphincteric 28, suprasphincteric 1.6, extrasphincteric 1.6. But he cannot put the fistula in the part classification in almost 20%, in 20%. It means that part classification is not reliable at all. If we look at the recent MRI classification of perianal fistula by the St. James University Hospital classification, if we look carefully what it is, because our friend, the radiologist, always love to report the St. James classification, but we do not understand what they mean. But in fact, if we look at this table, you can see very clear that it is the same as the part classification. It is the same. Only the difference is only that the high intersphincteric in the part classification, the high intersphincteric. Now it's put in grade 5 of the St. James University Hospital classification, high intersphincteric. So the part classification, I think there are many limitations or many drawbacks of the classification, and we cannot use it. So the St. James we cannot use too, in my understanding, in my opinion. You can see it's quite the same, these two classifications. There are many other classifications, and we will not talk about it. In summary, current fistula classification are not up to date, too simple or too complex. Part intersphincteric type does not separate low and high intersphincteric. Part transsphincteric type does not separate low and high transsphincteric. Part suprasphincteric and extrasphincteric types are extremely rare, and most of them are autogenic. It's not natural one. And I think we cannot use this classification in scientific study. We cannot use. The current anal fistula classification have many drawbacks, and hinder the development of fistula treatment. We cannot go further. We have a big barrier. We need new classification. A new classification may be accepted by some, but may also be strongly opposed by many others. Establishment of new fistula classification is unlikely to happen. So I will stop at the fistula classification, and then we have time for question and answer, and then we start the fistula patterns. The first part finished. We will start the second part later. And are there any questions now? Otherwise, we go to the second part, and then we can have the question and answer later. If you want me to continue, please let me know.
For the audience, if you have any question, please
send the question.
Please send the question via text box. At this time, I cannot see the question.
Maybe we continue?
Yes. Okay. We will move to the next. Please.
Look again. It's okay?
มาแล้วครับอาจารย์มาแล้วครับ
ไม่เห็น
สไลด์ยังไม่มา
Can you see? Okay. We will continue from the first part, the classification. We will continue with the patterns, the anal sepsis patterns. You can see The current anal-sepsis castration have limitation that I already explained, but it has been very used, very except for such a long period of time, maybe 40 years. At the moment, we cannot do anything. We cannot have a new castration. What will we do? I think a substitute concept parallel to the fistula castration is an alternate solution to this problem. So I propose the anal sepsis, absent fistula pattern. In fact, is an evolutionary concept from the many castration. This sepsis pattern is based on fresh cadaver anatomy with procedure and MRI finding. The anal sepsis pattern is the path of anal sepsis, absent fistula, of course, from the origin, the primary internal opening to external opening, or secondary internal opening, or by end. The anal sepsis pattern is predictable because anal sepsis space between muscle and space. Anatomy of anogenital muscle, I think not only anus, but anogenital muscle and space are constants. And anal sepsis pattern should be constant too. So I will explain more. I learned the anal sepsis patterns from three things. Anal anatomy in fresh cadavers. Anatomy of anus in fresh anal area in fresh cadaver is more clear than the formalin preserve. And we can see everything. We dissect from inside to outside, up and down in every direction for more than 100 cases of cadavers. We have the lift findings for 3,000, 4,000 cases. And we have imaging finding in many cases. And these three things and geo anal patterns of anal sepsis. Again, I say that it absent and fistula both. For the anatomy, I will give you very brief, a very sharp explanation of the anatomy, the three-level concept. I explain this three-level concept of the anogenital striated muscle, not only anus, but anogenital. You can see the upper level, the middle level, and the lower level. And the anal sepsis space between these three levels, between, not through the muscle, between muscle. Let's have a look at the upper level. It's the levator ani. The levator ani is a sheet of muscle, very thin muscle, attached to the pubic bone, attached to the arcus tendinous anterior. And then it attached to the tip of the coccyx, the side of the distal sarcum, the inner surface of the sarcum, distal sarcum, is a one sheet of muscle. But we can separate into people like this, people coccygeus, coccygeus only by location. But in fact, it's one sheet of muscle. The second, the middle level, in the posterior, the superficial external sphincter. Superficial external sphincter, which attached to the anal-coccygeal ligament. Anterior, it becomes attached to the superficial transverse perineum. And then in the anterior is a deep transverse perineum or perineal membrane. This is the middle levels. And the lower level is a subcutaneous external sphincter. The subcutaneous external sphincter attached to the bulbus cavernosus to the shaft of penis. If you squeeze this muscle, the penis raise up. or even the vagina. You can contract the vagina and the anus at the same times. So this muscle contribute to this. So this is three muscle level. And of course, the abscess and fistula, they pass or they lamify between these muscle, between, not through the muscle. And there are many space. You can see we have perineal space, need explanation, but we do not have time. We have perianal space, we have intersphincteric space, we have deep postanal space. I think we will explain later in other lecture. We have ischial space, we have infralevator space, and supralevator space. Infralevator space in the posterior here, they can come to the deep perineal space here. They can come. They can connect. But the ischial no connection to the anterior because is the transverse perineum is the barrier. Infection here cannot go anterior, but infection here sometimes they can go anterior. If we look at the intrarectal ultrasound, we also have T level. You can see this is the puborectalis level. You can see the puborectalis level. You can see this one, the loop of the puborectalis. In the second, in the middle, we can see the external and internal sphincter, internal and external. In the lower one here, we can see only the external, no internal. This is subacute external sphincter. As you can see, we have T level too. In the MRI, we also have T levels of the muscle. The levator ani here, very clear in the posterior, not very clear in the anterior. The superficial external sphincter here, and the subacute always like this, subcutaneous. If from fistula part here is a subcutaneous. So three level of muscle. By anatomy, by the lip finding, by the MRI finding, we can divide the anal sepsis pattern into 5 main types, 5 main patterns. And of course, they can combine together. We have the pattern 1, low intersphincteric. Pattern 2, low transsphincteric. Pattern 3, anterior high transsphincteric pattern. Pattern 4, posterior high transsphincteric pattern. Pattern 5, high intersphincteric pattern. We will go into the picture of each type. The type 1, the P1, pattern 1, low intersphincteric pattern. This is the abscess. This is the fistula. Pass between internal sphincter and subcutaneous external sphincter. This is not common. I think it's around 10% of the fistula is the low intersphincteric pattern. Not very common. The pattern 2 is the low transsphincteric fistula. The fistula or the abscess go to the perianal abscess here, but the tract, they pass into subcutaneous or between superficial and subcutaneous. So this is the low transsphincteric. This one, if it pass here, is very similar to the intersphincteric. If it pass here, is very similar to the high transsphincteric. But in fact, it's low transsphincteric because it passed between bundles of subcutaneous external sphincter. For the pattern number T, it's the anterior high transsphincteric pattern. The key point is the superficial external sphincter. This muscle, this fistula tract, pass above the superficial external sphincter in the anterior at 12 o'clock, at 1 o'clock, or at 11 o'clock most of the time. Only T position is quite common at 12, 1, and 11 o'clock. Anterior high transsphincteric fistula. For the abscess, you can see this is superficial external sphincter. The abscess come here under the penis and become the abscess here, become the abscess. Anterior high transsphincteric. For the number 4, pattern number 4 is the posterior high transsphincteric. The anal sepsis or the fistula tract pass above the superficial egg. The superficial egg is the key under the levator ani. In fact, there are T minor type. The most common one is this one. The fistula tract or the abscess go to the deep post space and then go ischioanal. This is the 80% of time is this. Sometimes it go to the intersphincteric and go out to ischioanal at 5 or at 7. This is intersphincteric type and come here. This is less common, maybe 15%. And the last one is the fistula pass above the superficial egg and go out through the anal coccygeal ligament, or sometimes it go up to the gluteus maximus. It can go up. But this type, the last one, they do not involve the ischioanal. The high transsphincteric without involvement of the ischioanal. So there are 3 possible patterns of posterior high transsphincteric pattern. Pattern 5 is a posterior high intersphincteric. They go up to the anorexia most of the time. They can go left and right to be a horseshoe, but most of the time they go like this and go to a little bit left or right in the intersphincteric to the supralevator space. In that case, the abscess can go up to the retroperitoneums. They can go as high as the pancreatic area, or the suprapubic area. I have seen many cases of this. Sometimes these abscess have a drainage, intra-anal drainage. So you can have the secondary internal opening, and the abscess can be resolute to be a tract between internal, primary internal, and secondary internal. Like this. This is the posterior high intersphincteric pattern. In summary, there are 5 types: low intersphincteric, low transsphincteric, anterior high transsphincteric, posterior high transsphincteric, and high intersphincteric. Of course, combination can occur. 1 can mix with 2, can mix with 3. It's more flexible. We can classify any fistula if we have the combination types. So combination can occur, but it's not common. The most combination type is the pattern 4 past pattern 5. And pattern 4 past pattern 5 is complex, highly recurrent, and need attention. In fact, this one, and in my experience, any recurrent fistula, any complex fistula, always this type, P5, like this. The fistula go up, high intersphincteric, maybe somewhere here too. At the same time, it's part of the levator, either intersphincteric or go deep post anal and go infra levator, like this. This is P4 part 0.5. It's highly subrecurrent. If with the lift, with the flap, or with any others, it's highly recurrent. Either research, study, everything is in the anal sepsis pattern. It is flexible and can be applied to near all types of anal sepsis, simple or complex, acute or chronic. You can apply to all. It can be converted to other classification, but not vice versa. It can be converted to any classification in future. The benefit of the anal sepsis pattern is facilitate interpretation of imaging. So if you understand this pattern, when you interpret the MRI or the intra-external side, it's much more easy. Easier, is easier. If you do not understand anything, it's much more difficult. It can guide surgical option. I will explain to you in the third part of my talk. It can reflect different treatment outcomes. It's much better than the classification. Useful for comparing outcome among users. Understanding and using this classification, this pattern, may reduce iatrogenic fistula. I will stop for the anal sepsis pattern now. So maybe some question now.
จันกลับไปสไลด์ที่มีรูป classification กันเราจะได้เห็นระหว่างที่จันเขาตั้งคำถามกัน
อันไหน
ย้อนกลับรูปที่เป็นรูปรวมสรุป classification จัน
โอเค
รูปนี้ครับจดกดเพลงครับแล้วก็เนี่ยครับเพราะว่าคนฟังก็จะเห็นรูปนี้สไลด์มา
Okay. We have one question from Kidaong, our friend from Myanmar. She asks that if all the classifications are not complete, how can we classify the fistula?
Oh, I already explained. Anyone who love any classification, just continue to use it. Just continue to use it. We will not against them. But I would like to recommend to pay attention and use the anal sepsis pattern parallelly. I mean, when you use a pattern, you will understand more and more. It means that I will not have new classification, but I will use pattern too, fistula pattern. It's parallel to the classification. You can use the patterns. That's my answer, because you have many classification, but I think it's not correct. But I will not change it. But I will use the patterns.
So it means that there's no perfect classification. So you move to the pattern of the fistula instead.
As I already explained, many surgeons believe in the available classification, and we cannot change them. We cannot change. But as I told you, fistula classification have many drawbacks. And anyone who report the fistula treatment with the old version classification is unreliable. I would like to say that it's unreliable. Those papers are unreliable in the past. That's why I said the fistula classification is the biggest barrier of fistula development. So I will use the pattern, and I recommend to use especially in our regions. I mean the Southeast Asia. We start first, and others, if they believe, if they try it, and they think it's benefit, they will use it.
There's another question from our friend Warmin. He asks that, in your opinion, what is the best treatment for P5 or complex P4 with P5 fistula in the
That's the third part of my talk. Wait, then you will see. That's the third part of my talk. We will talk about the treatment of every type of fistula.
Another question from the number 384 something. The anal sepsis is not passage muscle.
Correct. Pass between muscles.
And P4 and P5 are not the same muscle level.
P4 and P5. P5 is high up. It's go high up, but P4 and P5 can mix, can occur at the same times.
The next question is from Dr. Thilanut from the southern, our friend from southern of Thailand. She asked that it means that in type 1, the external opening is located above the anal wash.
No, I think Nearly all fistula, the internal opening is at the dentate line, except the anterior fistula. I think 30% of the anterior fistula, the internal opening located at the enoderm, at the not at the dentate line, 30% of the time. But if you look very close, it continues to the dental line in many cases too. This is very strange. I cannot explain why. In the anterior fistula, many internal opening is, the internal opening sometimes is at the enoderm because this against the cryptocandular theory. But that the nature.
Another question from Arun. Do we always need the preoperative imaging such as UAS, MRI in every case of fistula in the nose?
No, because those, yes, if you want to have the study, in academic study, you should have imaging study in nearly every case to be the evidence to support your report. But in real practice, we need the MRI in only some cases. It's easy for me. I always teach that if you put the finger into the rectum and you cannot find any thickening, especially the thickening around the anorectal ring. So those are pattern 1, pattern 2, pattern 3, pattern 4, never pattern 5. If you put a finger into the rectum and you cannot feel any thickening or induration at the anorectal ring, in my mind, these do not need MRI. These cases do not need MRI.
Next question from Amy Bonniel.
Good morning, Annie.
She asks that for a difficult in managing fistula in any way with a large size of internal opening, how should she manage it? Let's say that
in fact, this question should be at the end. But okay, I will answer now. If you have the large internal opening, sometimes we have a large fistula tract, and this have a high recurrence after lip operation. So this type of fistula, you have to look at it. What it is this a type 2, type T, type 4, or type 5? And you can operate according to the type of fistula. I will explain more in the next part of my lecture. So wait.
Next question from Direct Fang. He asks that can we use your classification in recurrent fistula in nose because the anatomy may be changed in case of recurrent fistula?
Of course, yes, you can. Even reoperation, you can use not the classification. I do not have new classification. I call it the fistula, the anal sepsis pattern. You can use the anal sepsis pattern. You can use, but you can add some explanation. Let's say P3 or P4 or P5 with extra sphincteric with extra sphincteric tract, and extra sphincteric tract may be the iatrogenic. You just add on the pattern, and you add on the more finding. Yes, you can do it. You should use even in the reoperation. You can use the anal sepsis patterns. And of course, you can use either acute or an abscess or fistula, everything you can use it.
Next question is next question from Joseph Philippine. Can you predict the subsequent fistula pattern after subsequent resolution of cryptocandular abscess?
Yes, of course. Very easy. the abscess, when it doesn't find a way out, the abscess become the only 5 pattern and all the combination of patterns. Just follow it. Just practice it. You will learn more and more and more because we will go to the wrong way, the right way. You will go to the correct way. You go in a smooth road and you understand many things more.
A question from Christian. Can endo-anal ultrasound be a substitute for MRI considering the high cost of MRI examination in our country?
In fact, the champion of indirect ultrasound is our friend, our beloved friend, Dr. Charles. Are you there? Are you here?
Charles.
Charles Sang is an expert in indirect ultrasound for the abscess and fistula. And recently, he used the ultrasound for more than 1,000. And he picked out 200 cases which never operated before. But he can use this pattern in the ultrasound finding. So I think that my anal sepsis pattern is supported by the interrectal ultrasound by Charles. I think he can give more information to our society in near future.
One more question from our friend Carlo from Philippines.
Hello, Carlo.
Can our pattern types be addressed by lift?
Yes, of course, yes. And the outcome are different. So let's go to the part 3. Let's go to the part 3, okay?
Okay. Now we will keep the rest of the question for...
Many questions are related to the treatments.
So can I ask add to your talk? You think that your new classification of the pattern will be benefit for the patient because we can predict the way to treat the fistula without harmful to the patient, right?
I already explained. You can see. This is the answer. You can see this is the answer, the benefit of the anal sepsis patterns. Everything.
Okay, let's start the third.
Yes.
Now we go to the third part of my talks. This part is a little bit longer than the 2 parts. Let's have a look at the treatment option for fistula in anal. This is the treatment option for anal sepsis. The available options, we have fistulotomy, we have Seaton, we have Chasura in India, we have ELAF endorectal advancement flaps. We have lift and modify of lift. Almax is Korean modification of lift. Sloft is an Indian modification of lift. Airport is the Japanese modification of lift. In fact, it's not the modification, but it's similar. Sorry to say that it belongs to the left, but it's similar. We have fifth, fistulotomy immediate, primary sphincteroplasty. The champion is our friend Pavesh Sheikh from India. Pavesh is the champion of the fifth. And we have VAS from Italy. We have FIRAC, we have IFTRAC, we have OTSC, and we have Perfect and Topis from Dr. Katz from India. The old one, we have Fabric-Glue, Fabric-Plug, we have collagen pairs and stem cell. We have all. But I select to use some. I do not use all. My practice this year, I use lift more often. I use fifth more and more. This year, I use fifth more than last year. And maybe next year, I use fifth more than this year. In the past, I used fistulotomy and marsupialized woundage. but now I use less and less and less fistulotomy and marsupial wounded. I use FIP instead of the fistulotomy and marsupial wounded. I show you the picture. Less and less sedans. The sedan that pass to the sphincter, but I use sedan for the drainage. Soft tissue sedan, I use sedan for the drainage, but not sedan that pass the muscle. I use less and less. Okay. So we have the operative option. We already have the pattern. I already explained both. Now we will matching both together. Let's have look at the P1. The P1 low intersphingtic patterns. I used fistulotomy past marsupial woundage in the past, but now I use fistulotomy immediate primary sphincteroplasty. In this case, I mean I repair the internal sphincter. I repair the internal sphincter. But you wonder, internal sphincter can be repaired? Everyone will wonder. But I think even we cannot repair, but the wound heal faster and less recurrent. So we should use it. The technique is how to suture. One, suture near the wound edge to make the wound a little bit inward, not inward. If you look at the low picture here, we suture here, the wound inward, the wound edge inward. Inward, it will not heal, it will break. But if you suture here, bigger tissue here, it will be a little bit inward, and this will heal. And the second notice, you can notice that I put the suture to the whole depth of the wound, to include the whole depth of the wound. This is how I do it. Suture near the wound edge involve the full thickness of the wound. For example, this is low intersphincter type. No, this is low intersphincter type, of course. Yes. Put it in, cut it, and you can see the internal sphincter here. And then clean the fistula tract, curate and burn and curate. You can see it's clean now. You can see the internal sphincter here. Now we suture, interrupted with Valkyrie 2. I do not know which suture material is the best. At the moment, I use YQ20 with the special needle, a thick needle. The needle that's used for the post-test suture, we call the UR6 needle because it's very strong. The needle is very strong. So I use interrupted YQ20 with the UR6 needle. Okay, like this. You can see this. And I will cut the stitch out at 2 weeks, but this stitch I cut out at 4 weeks. Now go to the next one. The low transsphincteric patterns. We can use the lift most of the time, but we can use the fifth too. We can use. This is the example. In this case, we have T fistula. We have T fistula. The first one is the low transsphincteric. This one goes to the superficial post-anal space, go into the dentate line, midline here. Number one. Number two is the intersphincteric, low intersphincteric. Go here. And the number three, the anterior high transsphincteric here. I do not have the many picture. I show you only a few for example. In this one, I use the fifth. The second one, I use lift. The third one, I use lift. Because this is very close, so I make only one incision here. You can see. Because I put the probe here, it's come to the superficial pores and the space, so I cut it here. And I repair it, interrupted, repair it. And I curate this tag. The second one, I use the lift for here and use the lift for here in the same wound. This is high tan, not low tan. And I put a tube into the ischioanal. In fact, this type is very rare, quite rare. Okay? And at 1 month, you can see it here very nice. Almost no wound here. But you can see this wound here. But you can see some stitch here, which I have to cut it out. This is the fifth. I always cut the stitch out at 4 to 6 months, 6 weeks. At 4 to 6 weeks, I have to cut it out. At the moment, I do not know which technique is the best, but the primary repair is good one. For the PT, anterior high tan sphincteric, the fistula, this is subcutaneous. This is superficial, the fistula attack pass here. You can see the fistula attack. In this case, you can use the lift, or you can use intellectual advancement flap. You can use it. This is the track here. Go to here. You can see this is the flap. I use the flap in this case. And it's here. This old picture. I used this many years ago, but nowadays I do not use the flap. I used flap in the past, but now I do not use. I use less and less flap. Now go to the P4 pattern posterior high tan sphincteric. As I told you, there are 3 types. This is the most common one. And you can use the lift. You can use the flap. Or you can use modified fifth. Or you can use Haley fistulotomy. I will show you this because this is a very old picture. I will not use this anymore. You can see the horseshoe one, infralevator. We just open it like this. Open it like this. And we cut open, lay open the pores and the space. Cut the superficial external sphincter open. If at the moment I will repair the external sphincter, family suture, I will repair, but I will open this. And of course, in this case, the infralevator space to the deep perineal space. Yeah. So I put it drain. Substitute here. So this is Haley fistulotomy. Nowadays I will show you here. The next case is the ischioanal abscess. It's bulging here. You cut it open here. The abscess come out here. And you open it here. And then you can see in this acute abscess, but no intersphincteric abscess. It's a tract, go to the postanal space and go ischioanal. But no intersphincteric abscess, even in acute abscess. 80% of the time in acute abscess, there are no intersphincteric abscess. So we can do the lift. We can do the lift here. Even this is acute abscess. But I think I'm very confident to use lift in acute abscess. The outcome is very good. And of course, in every lift nowadays, I will put a tube there. Even in the acute abscess or in the chronic fistula, I always use them in every case after lift. Use lift, use them. You have to use them every case. And you keep the den at least 2 or 3 weeks. And it's dry at 3 weeks, you remove it, it will heal. But if it's not dry, keep it for longer time, maybe 2 or 3 months, no problem. and sometimes it can heal. Now we go to the pattern 5. We call intra-anal fistulotomy. You can use leaf in acute abscess, just can, but this is better. In this case, the MRI show the high intersphincteric superelevator here. You can see the internal opening here. We just lay open to the anorectal ring. Just lay open it and marsupilate it. This is finished. So this is a good one. Intra-anal fistulotomy. In the case P4 part P5, posterior high transsphincteric. High transsphincteric go out to infralevator and high intersphincteric type. You can use lift with tube then. You can intra-anal fistulotomy and closure external sphincter tract. You can use. In this category, there are many modifications. And maybe you need some experience, but there are many modifications. I show you some, but this is not the whole, but some part. In this case, it's from Singapore, maybe it's a Maldives, operate in Singapore and have recurrent. Come to me, you have the fistula from here to the post-anal space here, go to the internal opening here. At the same time, it's a horseshoe intersphincteric, horseshoe in high intersphincteric superelevator, horseshoe here. Another external opening here. In this case, I do the lift. I do the operation with the lift, like the track to the internal sphincter here. And then I put a tube then here, curate from here to the horseshoe intersphincteric, high I curate here, curate from here, curate in every direction, and do the lift here, And this case we are lucky. This case it healed only one operation for many months without any problems. The next case we have external opening here. It looks very close, but in fact is a combination type, high transsphincteric, high intersphincteric. Internal opening is here. External opening is here. Internal opening is here. External opening is here. We can go to the deep post-anal space here. Open it, and then we cut everything. Cut, and then no, we do not cut the external sphincter. We from here open the post-anal space here. We preserve. We can cut it or we can preserve the superficial egg here. We preserve the superficial egg in this case. And then we continue to cut the internal sphincter up to anorectal ring, intra-anal fistulotomy in this case. And then we repair the external sphincter. We repair the external sphincter. And then we put a dent here. And high up internal sphincter, lay open the superelevator, we just lay open it. We just open it. We do not close it. And this case here very well too. Another case. This case you can see the abscess here is I think this is post-anal. And you can see here, this is the high intersphincteric, You can see intersphincteric and then pass to the infralevator. This is the infralevator. It goes down like this. So this is the P4 part P5. In this case, there are no external opening. So in the diagram, I draw this. From the internal opening, it go to here, it go up here, and pass the superficial egg here in the lateral, go to the infralevator here. So my plan is to lay open the intersphincteric, high intersphincteric, just lay open it. You can see no external opening. This cat have rectal pain for 2 or 3 years, and he visit many Many surgeons with MRI, but no one operate him. So I cut the internal. From the internal opening, I cut up, I cut down. I cut up and I cut down. This is the intersphincter. I cut a little bit up and I cut down. I cut down and I cut. All the picture are in prone position, Not lithotomy, in the prone position. So I cut up here, I cut down here, reopen it. And I curate, this one I curate to the pores inner space. And this one I curate to the infralevator space. Another one I curate to the high intersphincter, but high intersphincter very short here because the incision to anorectal ring. This incision is to anorectal ring. And then I must supply the wound edge. Our friend in this faculty, they sometimes they do not marsupialize. They just lay open, that's all. But I love marsupialize because in many cases it can stop the bleeding. This case come for follow-up. And everything very good. It's here very fast. But in this case, I would like to have the follow-up every week. And then I put my finger to the inward area and squeeze it. If the pus come out, it means that it's not healed. In case that when you pressure the bulging area before the hardening area and then nothing come out, it means that it will heal. Just doing it every week. Okay, I have many other cases, but if you ask questions, I will show you others. But in summary, there are 5 patterns of natural anal sepsis. Combination of P1 to P5 can occur, but not common. Combination of pattern 4 and pattern 5 is complex and need attentions. I think if you want to be a very good colorectal surgeon, you should pay attention to P4 plus P5, and then finally you can manage it. There are many treatment options for anal sepsis. Each anal sepsis patterns require appropriate procedure. And this picture is my summary of my options, my recommended option. You can take the picture and later you can understand more and more and more. So just take the picture. And if you do not understand, you can send the question and answer question to me. I try to explain to everyone.
We are ready for Q&A. I would like to start with the anonymous attendee. The question is why type 3 only occur at
Okay.
Okay. Why type 3 only occur at 11, 12, and 1 o'clock positions?
Type T is the anterior high turn. Type T is the anterior high turn. Anterior high turn. In nature, in our finding, the internal opening always at the 12 o'clock or at 1 o'clock or even at 1, 11 or 12. Very, very rare it occur at 3 o'clock or 9 o'clock. Very rare. Very rare. This is the most common finding in many thousands of cases. So I think anterior high turn always occur in the anterior, not lateral. And anterior high turn is very, very tricky, I would like to say. If you have the internal opening at 1 o'clock, sometimes you have the external opening at 11 o'clock. It go across, it can cross. It can cross. So maybe you need one more lecture. I will give you lecture next time, only anterior high turn fistula. Then there are many pictures of the anterior hiatal fistula. Okay.
So review the video again and again. One time is not enough to understand the whole fistula idea from problem.
Okay.
Keep in mind.
It's not
Again
difficult.
and again.
It's not difficult.
Well, I believe that most of the question about the surgical treatment already covered by the third talk. If you would like to ask any question, please text in the box. So another question from Joseph.
Current studies support the pathogenesis of complex fistula in.
Okay, moment please. Current studies supports the pathogenesis of fistula in being a complicated combination of histological, microbiological, molecular, and host factors contributing to the development and persistence of fistula. With the knowledge of the fistula pattern with or without fistula operation of choice to ensure healing.
I will tell you, when I talk to my patients, I always told them that one, in my experience, all fistula can heal. I said all, because I do not have any fistula that I cannot heal. Second, we can preserve your muscles. Third, many times you need second operation or even the third operations. When the patient come to me, I always told them that I'm not very expert. I can heal you 80% with one operation. It means that 20% of the case you need second operation. So you need one operation. In few cases you need second operation. Very few cases you need third operation. But I guarantee all fistula can heal with most of the time only one operation, but many times. But in a few cases you need second or third operation, but all fistula can heal. Except you have the fistula with other disease, like a tuberculosis or the inflammatory bowel disease. That another purview, that another topics. Much more difficult. If you have a Crohn's disease, many cases not difficult, but a few cases of Crohn's fistula, very, very difficult.
Two questions from Dr. Ton. Some cases are so difficult to identify the tract in the optic field. What is your suggestion to identify these tracts?
Your question is not clear, but I try to explain. If you use the lift procedure, when you go into the intersphincteric tract, intersphincteric plane, but you cannot find the tract. You look left and right, but you cannot find. Then there are many techniques. First, maybe you put a probe in the tract, and maybe you can have some clue. Second, maybe you start calling out from the external opening, calling out, and then you can reach the intersphincteric plane and you can see. But sometimes you need experience. I do not know how to explain. But sometimes intersphincteric tract, sometimes you cannot identify. Very few cases you cannot identify. Second, if you do, when I was young, I went to Professor Goldberg. I go into the theater with him, and then he handed me a cautery, a probe, and he said to me, do the fistulotomy. Because at the time they do not allow the visitor to do the operation, but he is a very kind surgeon. In fact, he is very kind surgeon. I always respect him, Professor Goldberg from Minneapolis. then the best way to identify the track is to follow the track. So just open it and open it again and follow it. You will follow. But in that case, when I follow it, it stopped. It stopped one centimeter near the anovus, and we cannot go anywhere. Then Dr. Gober asked, what's next? What to do? I told him at that time, stop, finish. So I finished. He said, yes, correct. So I want to ask your question that sometimes we cannot identify the track. Yet, but very few cases. Very few cases.
The next question is, in case of left ischial abscess, but the MRI show bilateral psoas abscess, how this process can occur, which pathway?
Oh, if you learn the deep port in space, or even in the intersphincteric plane, the abscess from the posterior sometimes it go both sides, but it rupture through the external opening only one side, and the rest can collapse. But it's still there. I mean, if you have the high transsphincteric posterior, you can have external opening on one side, but still active fistula tract in the opposite side. You can see the horseshoe, but only one external opening, not the opening from the other. But this just do the lift. You can do the lift and curate and put the tube in, or make another external opening on the opposite side, the side that not ruptured before. You can put two tubes in.
And what kind of tube then you use and which size?
In the past, I use soft tissue season. I use vessel loop. But nowadays, I use the plain catheter. I mean, dilatant urinary catheters. In the past, I used number 14. I think the bigger is the best, but I do not believe anymore. Nowadays, I use number 10. I use number 10 plain catheter, but I put two. I put two tube. I put number 10, but two tube. Because in the second week, I remove one. And I have another one. For another next week or another 2 weeks, it means that we have more follow-up. We have to look over more time to look at the patients. And of course, a bigger drain, bigger tube drain, it have big hole. In my understanding, it's difficult to heal. If I put two tube, number 10, I remove one, the tract become very small. And then I remove the others. This is my trick.
Next is my question. From your summarization, for the P3 anterior high transsphincteric fistula and AO, why you don't recommend to do the fifth for treatment in P3?
P3 you can do fifth. In fact, you can do fifth. But the fifth in PT anterior high transsphincteric, would mean that you have to cut the subcutaneous and superficial external sphincter. And in the anterior, the levator ani is very thin, or we do not have levator ani. In fact, there are some fiber from the levator to the prostate gland in male, and to the few fiber in female too. But we believe that there are no tuberculosis in the anterior, or very big and small. If you cut the external sphincter and with maybe some infection and it's there, you can end up with the incontinence. So I use knife in the anterior, or I use modified fifth. It's now more confused. Why modify fifth? I cut the internal sphincter I cut the internal sphincter. I cut the external fistula tract, very open. And then I repair the external sphincter wall. And then I cover the external sphincter repair with the internal and mucosa. So I do not cut the muscle, but I repair the hole. So there are many modifications nowadays, many modifications.
So can I ask that you said that it's more modification? That means like if we are not expert like you, we found that this type of fistula, we thought that we can do it. So we go into the operative theater, starting operation. What is the thing that make us stop? What is the point that we should stop and send to the more expert?
If you have learned the fistula pattern, and if you have some experience with the lift, I think you can manage nearly all fistula, nearly all. Very few you cannot do it. Very few.
So it's like if we cannot find the tag.
If you cannot do anything, stop and finish. That's all. Close the wound. That's all. Do not cut more muscle. Do not cut muscle. Okay, it's done.
The next question is from Joseph Roy. Have you got any long-term outcome from fifth in terms of incontinence rate?
I do not have, because I started fifth in only 2 years. I think I operate nearly 200 cases, 250 in the past 2 years with the fifth. And so far, with the verbal, with the question, with the oral question, every patient seems normal. But I do not have the manometry to support. In the report from others, many others from our friend, they said that no problem of the incontinent problems. And in my experience, they will faster than it look normal. And the patient said that they have good control. So I do not have the manometry to support. But the patient satisfied, so I'm satisfied too.
Another question from David about a large intersynclic cavity or abscess. Will it be quite difficult to lift? And the plate is fibrous and maybe difficult to identify the tract. So it's quite difficult to do lift for the large cavity at the intersynclic plane.
Your question is quite opposite. You said big cavity, but you have fibrosis. It's difficult. But nowadays, I use it moderate time, yes, but sometimes I use fifth. So you can understand that fifth is good, but to suture the muscle, you have to have two concepts. First, you have to put to suture. You have to put the suture deeper than the base of the wound. In case you cut the external subcutaneous superficial external sphincter, you can suture 2 layers. One into the muscle, go above the wound base, include all the muscle and suture. You have to go under the wound, go under and sutures. And then the next layers, you should go to the skin, past the suture muscle, and correlate, so that there are no net space. You have to do this. But the outside, the distal fistula tract or cavity, you can lay open, of course. But the muscle near the internal sphincter, you have to suture really well, unless it will break down. And maybe you have to look at the operative by Pavet or recommended by some Italian surgeon how to suture the external sphincter.
The next question from Apicia. Why do you only rarely use Seton these days compared to the past? When do you remove the first and second catheter?
Do we have time?
Yes.
If we have time, we will have 2 or 3 minutes for the season. Is okay?
Okay.
It's okay. I have many lecture, but it takes time. So why I do not prefer season? In fact, I use season for long times. And I even go to India and bring back many Sutra and use it for a period of time. But I use less and less season. I have this is my explanation. Can you see? We take 2 or 3 minutes. Seton, we have cutting seton and loose seton. Cutting seton is not popular in Europe, in Western America, but loose seton very popular. The right hand one, this seton from Spain, but in fact this seton is incorrect. The tag is not here, the tag come here further. So it's not correct. Incontinence rate after cutting seton is 12%. Some paper even 30%.
Last question.
Okay, seton have incontinence. Let's have a look at the international practice of seton. Italy, they said they use loose seton. They do not recommend chemical seton, I mean Sutra from India, for simple fistula. It means that they do not discuss about the high fistula. In Germany, they said loose seton and require second operation. Cutting seton should not be continued. In Germany, they said no cutting seton. In UK, they said loose seton and second operation. And they cutting seton only when other technique fail. They use less and less cutting seton in UK. Just loose seton. And loose seton followed by definitive procedure. You can see loose seton, and loose seton. And in cutting seton in complex fistula, with caution, it means that this country, they do not prefer cutting seton, but they use loose seton. If we look at in Asia, you can see in Saudi, they use cutting seton. In China, very popular. I have many pictures, but I cannot show you here. Of course, in India, Sutra is quite popular. I visit Dr. Sahu. He operates maybe 100 cases a day. 100 cases a day with seton. So in a year, he have 10,000, 20,000. That the biggest hospital case number in the world, in India, in one hospital, in Varanasi hospital, they use Sutra. So it should be good, otherwise it should stop. I bring back Sutra and I try many cases, but it failed. I cannot duplicate it. So I stopped using it too. In Japan, they do not like cutting seton because they have said significant. These are practiced in Europe and Asia. Cutting seton. Risk of incontinence, yes. Loose seton is a waste of time, but it's good for surgeon because we have 2 operations. We have 2 time doctor fee, but I think it's not necessary because in my operation, even in acute abscess, I operate 1 step. Seton may cause false tag and create complex fistula. So seton is good if you are experienced surgeon. But seton should not be used by general surgeon. In fact, I would like to teach them to put the tube then in any abscess cavity or fistula tract. Use the tube then is better than sedent to drain, to make a tract more mature. Tube then it have no harm. Tube then is better than sedent. Sedent cannot drain the high abscess. If you have a high abscess, let's say infiltrator, and you use the sedent to part the superficial external sphincter, the upper abscess, upper cavity will not resolve. So this is the drawback of sedent. So I do not use sedent. If you want to drain any cavity, put a tube then it's better than the sedent, easier and do no harm. Okay, that's all my talk about the sedent.
Well, we have only the two more questions. The first one from YH on. In cases we cannot find the internal opening, what's your suggestion?
We cannot find the internal opening. First, when we inject water or solution, it cannot go out to the internal opening. When we inject water or water mixed with hydrogen peroxide, and we cannot see the bubble come out from the internal opening, that we cannot find. Second, when we put the probe, it cannot go to the area near the rectum or the anus. So we do not know. So there are many techniques to do in this scenario. First, you start coring out the fistula tract until you go to the area near the anovus. Then you make an incision and do the lift. You can make a coring out. But I think in my experience, maybe 1%, you cannot do anything to find the internal opening. You do what you can do. You can do the lift, or you can just curate out the fistula tract, anything. But not all the time there will be no problem to identify the internal opening, either by water injection, by probing, or coring out from the external opening. That's all I have.
The last question from Tida. Sometimes the internal opening is difficult to close as the tissue is friable. Any tips for her, please? Internal opening is difficult to close because
it means that we cannot ligate the intersphincteric tract or something.
I believe it's the fistula tract on the internal sphincter side.
Fistula tract on the internal sphincter tract. At the moment, I use two techniques. One, lift. Second, cut open and repair. So you can use the second.
Cut the tract or cut the muscle?
Cut everything. Lay open the tract, even the muscle is there, cut it, and then repair. But the problem is you should have a good repair. Otherwise, we break. A good repair, no problems. We have no problem. It can heal. Okay.
Okay. Thank you, Professor Arun. Thank you for your contribution. And we have run out of time. We have to close this webinar. Thank you for all the audience. And we will have the webinar about the pelvic floor descent recently.
Later, we will announce again.
Oh, it's a pelvic floor disorder from basic to clinical practice on August 20 at 12 p.m. Oh, sorry, 2 p.m. Okay, 2 p.m. afternoon. Okay, thank you all.
Okay. Thank you.